After discussing an introduction to the cardiovascular system in the previous lecture, today we'll start discussing hypertension in simple and entertaining illustrations as usual. In this video we'll discuss the essential pathophysiology of hypertension, so we could have fun discussing the categories of the drugs used for it in the upcoming lectures. The first thing we should know is, what is hypertension? Hypertension is defined as either a sustained systolic blood pressure of greater than 140 mm Hg, or a sustained diastolic blood pressure of greater than 90 mm Hg. Hypertension results from increased peripheral vascular arteriolar smooth muscle tone. In other words, hypertension is a state of elevated blood pressure, which is the pressure exerted on the walls of arteries. Systolic blood pressure is the blood pressure during systole or myocardium contraction, and diastolic blood pressure is the blood pressure during diastole or myocardium relaxation. That leads us to the classification of the blood pressure. The normal blood pressure, lesser than 120 for the systolic, and lesser than 80 for the diastolic. And pre-hypertension, from 120 to 139 for the systolic, or from 80 to 89 for the diastolic. Stage 1 hypertension, from 140 to 159 for the systolic, or from 90 to 99 for the diastolic. And Stage 2 hypertension, equals to or greater than 160 for the systolic, or, equals to or greater than 100 for the diastolic. Although many patients have no symptoms, chronic hypertension can lead to heart disease and stroke. It is also an important risk factor in the development of chronic kidney disease and heart failure. Hypertension may occur secondary to other diseases, but more than 90% of patients have essential hypertension, that happens with no identifiable cause. There are some risk factors we should know. The family history of hypertension increases the chance to develop hypertension. Older ages, diabetes, obesity, smoking, alcohol consumption, stressful lifestyle, and high dietary intake of sodium are also risk factors for hypertension. Now let's understand the mechanisms involved in the control of blood pressure in the body, and that definitely would help us in understanding how the drugs work. There are multiple organs involved in the control of blood pressure: the heart, blood vessels, kidneys, liver, and lungs. There are two major processes control these organs to work in harmony in controlling blood pressure. The baroreceptors in the sympathetic nervous system. And the renin-angiotensin-aldosterone system. So what happens when the blood pressure falls? Before we begin, you should know that three processes increase the blood pressure: increasing cardiac output, increasing peripheral resistance, or increasing blood volume. A fall in blood pressure causes pressure-sensitive neurons in the aortic arch and carotid sinuses, that are called baroreceptors, to send fewer impulses to cardiovascular centers in the spinal cord. This prompts a reflex response of increased sympathetic and decreased parasympathetic output to the heart and vasculature, resulting in activation of beta-1 adrenoreceptors in the heart, increasing cardiac output, and activation of alpha-1 adrenoreceptors in the blood vessels, causing vasoconstriction, leading to a compensatory rise in blood pressure. The kidneys control the blood volume. Simply, when blood pressure falls, the kidneys release the enzyme renin, leading to a series of events that increase blood pressure. Let's discuss more details. There are also baroreceptors in the kidneys. They respond to reduced arterial pressure, and to sympathetic stimulation of beta-1 adrenoreceptors in the kidneys by releasing the enzyme renin. Low sodium intake and greater sodium loss also increase renin release. Renin converts angiotensinogen, which is synthesized in the liver and secreted in plasma, to angiotensin 1, which is converted to angiotensin 2 in the lungs, in the presence of angiotensin converting enzyme, ACE. Angiotensin 2 is a potent circulating vasoconstrictor, constricting both arterioles and veins, increasing peripheral resistance and blood pressure. Angiotensin 2 also stimulates aldosterone secretion, leading to increased renal sodium reabsorption and increased blood volume, which contribute to a further increase in blood pressure. These effects of angiotensin II are mediated by stimulation of angiotensin II type 1, AT1, receptors. So we can conclude the categories of the drugs that are used for hypertension: either they work as sympatholytics to decrease the sympathetic activity, interfere with renin-angiotensin system, or diuretics to decrease blood volume. And each of these categories is further subdivided to other groups. In this lecture we'll discuss the sympatholytics that can be used to manage hypertension. As we know from the lectures of ANS, sympatholytics could be divided to centrally acting, alpha or beta blockers, both alpha and beta blockers, adrenergic neuron blockers. Note that, all what we'll discuss in this lecture, have been discussed in details in separate lectures before in the ANS chapter. The centrally acting agents such as, clonidine, alpha-methyl-dopa, and the newer generation moxonidine and rilmonidine. Let's briefly discuss their mechanisms. Clonidine acts by stimulation of central alpha-2 receptors, and that decreases the sympathetic outflow to the periphery, so decreases total peripheral vascular resistance and decreases blood pressure. It is used primarily for the treatment of hypertension that has not responded adequately to treatment with 2 or more drugs. It is particularly useful in the treatment of hypertensive patients with concomitant renal disease, as it does not decrease renal blood flow or glomerular filtration. Its adverse effects include sedation, dry mouth and constipation. Rebound hypertension occurs following abrupt withdrawal of clonidine, so it should be withdrawn slowly if discontinuation is required. Alpha-methyl-dopa acts by inhibition of dopa decarboxylase enzyme, which converts dopa into dopamine. And as we know, dopamine is a precursor for norepinephrine and subsequently epinephrine. This inhibition results in reduced dopaminergic and adrenergic neurotransmission in the peripheral nervous system. It is converted to alpha-methylnorepinephrine by dopamine beta-hydroxylase. Alpha-methylnorepinephrine is an agonist of presynaptic alpha-2 adrenergic receptors. Activation of these receptors in the brainstem inhibits sympathetic outflow and lower blood pressure. The most common side effects of methyl-dopa are sedation and drowsiness. It is mainly used for management of hypertension in pregnancy. Moxonidine is a selective agonist at the imidazolin receptor subtype 1. This receptor subtype is found in specific areas in the medulla oblongata. It therefore causes a decrease in sympathetic nervous system activity, and therefore a decrease in blood pressure. And the last agent in this category, rilmonidine, shows greater selectivity for imidazolin receptors than for cerebral alpha-2 receptors. Side effects include dry mouth, sedation, fatigue and dizziness, but they are less pronounced with the newer generation. Now let's move to the beta blockers. Beta blockers are a treatment option for hypertensive patients with concomitant heart disease, such as supraventricular tachyarrhythmia, previous myocardial infarction, angina pectoris, and chronic heart failure. The beta blockers reduce blood pressure primarily by decreasing cardiac output, by blocking beta-1 receptors in the heart. They also block beta-1 receptors in juxtaglomerular cells in kidneys, so inhibit renin release, thus decreasing the formation of angiotensin II and the secretion of aldosterone. They may also decrease the sympathetic outflow from the CNS, by blocking the presynaptic beta receptors. The prototype beta blocker is propranolol, which acts at both beta-1 and beta-2 receptors. Selective blockers of beta-1 receptors, such as metoprolol, atenolol, bisoprolol and acebutolol. Nebivolol is a selective blocker of beta-1 receptors, which also increases the production of nitric oxide, leading to vasodilation. Let's discuss their actions and contraindications in brief, and for more information you can watch the beta blockers lecture in the ANS chapter. The non-selective beta blockers, such as propranolol and nadolol, are contraindicated in hypertensive patients with asthma, due to their blockade of beta-2 receptors in the lungs, causing bronchoconstriction. And the selective beta blockers may be administered cautiously to patients with asthma. Beta blockers should also be used cautiously in the treatment of patients with acute heart failure or peripheral vascular disease, and with diabetic patients, as they potentiate the hypoglycemic activity of insulin and oral hypoglycemic drugs, due to blocking of hepatic beta-2 receptors mediated glycogenolysis. Their adverse effects include bradycardia, hypotension, and CNS side effects such as fatigue, lethargy and insomnia. They may decrease libido and cause erectile dysfunction. They also may disturb lipid metabolism, decreasing high-density lipoprotein cholesterol, and increasing triglycerides. Abrupt withdrawal may induce angina, myocardial infarction, and even sudden death in patients with ischemic heart disease. So it should be withdrawn slowly over a few weeks. And now let's move to the alpha blockers. Prazosin, doxazosin, and terazosin. They are selective competitive antagonists at alpha-1 receptors in the blood vessels, causing vasodilatation and decreasing blood pressure. Reflex tachycardia and postural hypotension often occur at the onset of treatment, and with dose increases, requiring slow titration of the drug in divided doses. Alpha blockers are no longer recommended as initial treatment for hypertension, but may be used for refractory cases. And there are some agents that block both alpha and beta receptors such as labetalol and carvedilol. Carvedilol is an effective antihypertensive agent, but is mainly used in the treatment of heart failure. Labetalol is used in the management of gestational hypertension and hypertensive emergencies. And the last category we'll talk about today is the adrenergic neuron blockers, and exactly we'll discuss one of them, that is still in use. Rezapine inhibits granular uptake and storage of biogenic amines, such as norepinephrine, dopamine, and serotonin, from the cytoplasm into storage vesicles in the adrenergic nerve terminals in all body tissues. And this causes depletion of biogenic amines. So of course the sympathetic function is impaired, because of decreased release of norepinephrine. It has been used for the management of hypertension, but has largely been replaced with newer agents with better side effect profiles, and fewer drug interactions. As we already know from the hypertension pathophysiology lecture, kidneys respond to reduced arterial pressure, and to sympathetic stimulation of beta-1 adrenoceptors by releasing the enzyme renin. Renin converts angiotensinogen, which is synthesized in the liver and secreted in plasma, to angiotensin 1, which is converted to angiotensin 2 in the lungs, in the presence of angiotensin converting enzyme, ACE. Angiotensin 2 is a potent circulating vasoconstrictor, constricting both arterioles and veins, increasing peripheral resistance and blood pressure. Angiotensin 2 also stimulates aldosterone secretion, leading to increased renal sodium reabsorption and increased blood volume, which contribute to a further increase in blood pressure. These effects of angiotensin 2 are mediated by stimulation of angiotensin 2 type 1, AT1, receptors. Now we can conclude how the drugs may interfere with this mechanism. Either they inhibit renin itself, inhibit angiotensin converting enzyme, or block angiotensin 2 type 1, receptors. Let's start with the angiotensin converting enzyme inhibitors, or known as ACE inhibitors, such as Captopril, Enalapril, Ramipril, Fosinopril, Lisinopril, Moexipril, Perindopril, Quinapril, Moexipril, Enalapril. If you notice, all of them end with the part pril. They are recommended as first-line treatment of hypertension, in patients with a variety of compelling indications, including high coronary disease risk, or history of diabetes, stroke, heart failure, myocardial infarction, or chronic kidney disease. These drugs block the enzyme ACE, which converts angiotensin 1 to the potent vasoconstrictor angiotensin 2. ACE is also responsible for the breakdown of bradykinin, which is a peptide that increases the production of the potent vasodilators, nitric oxide and prostacyclin by the blood vessels. So the net result of inhibition of ACE would be decreased angiotensin 2 and increased bradykinin level, leading to vasodilation of both arterioles and veins. and we can conclude that, by reducing circulating angiotensin II levels, ACE inhibitors also decrease the secretion of aldosterone, resulting in decreased sodium and water retention. So ACE inhibitors reduce both cardiac preload and afterload, decreasing cardiac work. Common side effects of them include dry cough, rash, fever, altered taste, hypotension, and hyperkalemia, so potassium levels must be monitored during the use of ACE inhibitors. The dry cough occurs in up to 10% of patients. It is thought to be due to increased levels of bradykinin and substance P in the pulmonary tree, and resolves within a few days of discontinuation. Angioedema may occur. It is a rare, but potentially life-threatening reaction, that may also be due to increased levels of bradykinin. Serum creatinine levels should also be monitored, particularly in patients with renal diseases. ACE inhibitors are teratogenic, they can induce fetal malformations, so they should not be used by pregnant women. The second category we'll talk about is the angiotensin II receptor blockers, such as losartan, valsartan, irbesartan, candesartan, olmesartan, eprosartan, telmisartan, azilsartan. If you notice, all of them end with the part sartan. Similar to ACE inhibitors, these agents may be used as first-line agents for the treatment of hypertension, especially in patients with a compelling indication of diabetes, heart failure, or chronic kidney disease. They are alternatives to the ACE inhibitors. These drugs block the AT1 receptors, inhibiting the activation of AT1 receptors by angiotensin II. Similar to ACE inhibitors, they produce arteriolar and venous dilation, and block aldosterone secretion, thus lowering blood pressure, and decreasing salt and water retention. But they do not increase bradykinin levels, so they are less likely to produce dry cough and angioedema. Other adverse effects are similar to those of ACE inhibitors. You should note that, these agents are also teratogenic and should not be used by pregnant women. These agents should not be combined with ACE inhibitors, due to the similarities between them. And finally, the third category is the renin inhibitors, such as aldosterone. It directly inhibits renin, and it lowers blood pressure about as effectively as ARBs and ACE inhibitors. It should not be combined with an ACE inhibitor or ARBs. Aldosterone can cause diarrhea, especially at high doses, and can also cause cough and angioedema, but probably less often than ACE inhibitors. As with ACE inhibitors and ARBs, aldosterone shouldn't be used during pregnancy. The first thing we need to know, what are calcium channels, and what are the roles of the calcium ions in the body? Briefly, the intracellular concentration of calcium plays an important role in maintaining the tone of smooth muscle and in the contraction of the myocardium. Calcium enters muscle cells through special voltage-sensitive calcium channels, and this triggers release of the intracellular stores of calcium, from the sarcoplasmic reticulum and mitochondria, which further increases the cytosolic level of calcium. So what the calcium channel antagonists do is that they block the inward movement of calcium, by binding to L-type calcium channels in the heart, and in smooth muscle of the coronary and peripheral arteriolar vasculature. This causes vascular smooth muscle to relax, mainly dilating arterioles, but they do not dilate veins. Calcium channel blockers are a recommended treatment option in hypertensive patients with diabetes, or angina. The calcium channel blockers are divided into 3 chemical classes, each with different pharmacokinetic properties and clinical indications. Diphenylalkylamines, such as verapamil, is the least selective of any calcium channel blocker, and has significant effects on both cardiac and vascular smooth muscle cells. It is also used to treat angina and supraventricular tachyarrhythmias, and to prevent migraine and cluster headaches. Benzodiazepines, such as diltiazem, it also affects both cardiac and vascular smooth muscle cells, but it has a less pronounced negative inotropic effect on the heart compared to that of verapamil. Diltiazem has a favorable side effect profile. Dihydropyridines, such as nifedipine, amlodipine, falodipine, isradipine, nicardipine, and niziolidipine. If you notice, all of them end with the part dipine. All of them have a much greater affinity for vascular calcium channels than for calcium channels in the heart. So they are particularly beneficial in treating hypertension. This category have the advantage that they show little interaction with other cardiovascular drugs, such as digoxin or warfarin, which are often used concomitantly with calcium channel blockers. So briefly, what are the therapeutic uses of the calcium channel blockers? They are used in the management of hypertension. They may be used as an initial therapy or as add-on therapy. As we said, they are useful in the treatment of hypertensive patients who also have asthma, diabetes, or peripheral vascular disease, unlike beta blockers that adversely affect these conditions, as we mentioned in the previous lectures. All of calcium channel blockers are useful in the treatment of angina. In addition, diltiazem and verapamil are used in the treatment of atrial fibrillation. And finally, let's talk about their adverse effects. Verapamil has common dose-dependent side effects, which are first-degree atrioventricular block and constipation. Verapamil and diltiazem should be avoided in patients with heart failure or with atrioventricular block, due to their negative inotropic and ramitropic effects, which means decreased force of cardiac muscle contraction and decreased velocity of conduction, respectively. Dizziness, headache and a feeling of fatigue caused by a decrease in blood pressure, are more frequent with dihydropyridines. Peripheral edema is another commonly reported side effect of this class. Nifedipine and other dihydropyridines may cause gingival hyperplasia. That's all for this lecture. In the next lecture we'll discuss the diuretics. If this lecture was useful for you, leave like and a comment of your opinion, subscribe if it's your first time here and keep following us.